Two, one. Good afternoon from Miami Beach. This is Dr. John Bennett, broadcasting for Neurosurgical TV. Uh, we have two presentations today from the future neurosurgeons of Africa, the Associate Future Neurosurgeons of Africa. And the first speaker is Natalie. But first, let's go around the. Oh, I'm sorry, Ulrich. I'm sorry. I forgot totally. I'm sorry, Ulrich. Let's
It's
start
all right.
this. Let's
It's
start
all right,
this again.
John.
No, we'll start this again. Ulrich, I'm sorry. Okay, we can start this again. I don't know where my mind's at. Okay, anytime you're ready. Okay.
Okay.
Just edit. We'll just edit the first my part out.
No, don't worry. Hello, everyone. It's Ulrich Sidney here, President of the Association of Future African Neurosurgeons. Today is the first couple of presentations for the year 2020. We're so happy to have all of you here. The very first presentation would be by Dr. Natalie, PGY1 resident in neurosurgery at Abidjan. But before we start, we're going to have the different members, the people around, present themselves. So Dr. Abdullahi Jimo. You're muted, Dr. Jimo.
Yeah, everyone, and welcome to 2020. We hope this year will be a fantastic year in the program, and some of us will be more available. I am Jimo. I'm a neurosurgeon in Nigeria, but I'm currently in Rabat, Morocco for fellowship in stereotactic gamma knife and functional neurosurgery. Thank you, Eric.
Thanks, Dr. Jimo. Dr. Leo Yanu, can you present yourself, please? Please unmute yourself, please.
It's okay?
Yes, great.
Okay. Hello, I'm Leo Yanu. I'm a medical doctor from Cameroon, general practitioner and aspiring neurosurgeon.
Nice to meet you. Thanks for being here. Dr. Igor Nietzsche, can you present yourself, please?
My name is Igor Nietzsche. I'm from Cameroon. I'm second year residency in neurosurgery at Abidjan. I'm happy to be here.
We're happy to have you as well. Thanks very much. Dr. Marco Meloni.
Hello, everybody, and Happy New Year to everybody. My name is Marco Meloni. I'm a consultant neurosurgeon in Gravedona, North Italy.
Yes, always a pleasure to have you around. Dr. Augustino Jacinto. Dr. Augusto Jacinto. I think you're muted. You will want to unmute yourself first.
Hello.
Hello.
I'm here. I'm talking from Mozambique.
Yes, we can see
Hello.
you.
Hello. I'm talking from Mozambique.
Okay, great to have you.
Thank you.
Obrigado.
Happy New Year.
Happy New Year. Dr. Aminata Salah, can you present yourself, please? Maybe you're muted because we can't see you. We think maybe you're speaking and we can't. Okay, no worries. Now that everyone's presented themselves or muted themselves, we're going to have Dr. Natalie give a presentation. Please, everyone, mute yourselves. Go ahead, Dr. Natalie.
Okay. Hello, everyone, and Happy New Year to AFN and all those who associate with AFN. Sorry for the late coming. I thought I was presenting after Daniel. So today I'm going to present on, let me just say, complete my presentation on the management of acute ischemic stroke. Today I'm going to present on the surgical indications of ischemic stroke. As we said, as we said previously, the WHO defines stroke as the sudden onset of focal neurologic dysfunction in which, after adequate investigation, symptoms are presumed to be non-traumatic but of vascular origin, and it lasts for more than 24 hours. Cerebral ischemia is caused by the reduction of in cerebral blood flow, as you can see, that lasts longer than several seconds. The etiologies are many, which the main etiologies are we can find cardioembolic etiologies, embolic etiologies, or thrombosis. But uncommonly, we can also find the Moya disease. In our country, have already been faced with a case of ischemic stroke after eclampsia. Current available medical treatment of ischemic stroke includes thrombolysis and anticoagulants to deal with the later complication of malignant edema and raise intracranial pressure. Medical treatments such as mannitol, hypertonic saline, and barbiturate coma, or hypothermia or hyperventilation have been proposed, which are reasonably proportional, but they are not really effective. These medical solutions to treat malignant edema has not proven effective, have been effective in preventing breath herniation and improving patients' outcome other than surgical treatment. And that's what we'll focus about today. The surgical treatment for stroke can be classified into either an acute or a non-acute treatment. Acute interventions are usually initiated within hours of stroke onset, and they are aimed at reestablishing the cerebral blood flow, restoring the loss of neurologic function, and preventing permanent tissue damage. While the non-acute surgical therapies focus on reducing secondary injuries resulting from brain swelling or preventing recurrent stroke. As for the main acute intervention, we have the endovascular mechanical thrombectomy. We talked about it on the last presentation some few weeks ago, which consists of clot retrieval. Usually the indication here is patients who have the contraindication for thrombolytic treatment, or those who fail to achieve vascular recanalization with IV thrombolytics. Here we have an image which shows two different types of clot retrieval. Here is the penumbral clot retrieval, and here is the stent clot retrieval. 10% of ischemic strokes result in large areas of infarction. This can lead to significant brain swelling, an increase in intracranial pressure, and in severe cases, life-threatening herniation syndromes. As you can see, we have the cingulate herniation, we have transcalvaria or extracranial herniation, orchid herniation, upward cerebral herniation, or even tonsillar herniation. For the anterior circulation, the decompressive hemicraniectomy is usually proposed. Usually when there is a significant edema that occurs in the supratemporal space after a stroke, it is referred to as malignant infarction of the middle cerebral artery. How is it done? What's the technique? After a standard question mark in skin incision, we will perform a muscle and soft tissue reflection, anterior reflection. And then we create a bone flap with at least 3 burr holes. The bone flap is then removed anteriorly and posteriorly. We remove the bone flap, and the residual temporal bone is cut by rongeurs down to the floor of the middle cranial fossa for maximal decompression of the brain stem after removing the bone flap. Then we proceed to a dural opening. That's we perform a radial incision of the dura mater in order to maximize cerebral decompression. Underneath the dura mater, usually we have the zone of infarct, the zone of ipta, which can be resected. Then we close the skin scalp with a suture or a staple. There continues to be a considerable amount of interest in the use of decompressive hemicraniectomy in the context of malignant middle cerebral artery infections. There is now a significant amount of evidence that it is a life-saving intervention. However, it is by no means restorative, and many patients will survive but remain dependent, especially those patients over 60 years of age. For those patients on whom surgery is considered beneficial, there remain some issues regarding the timing of surgery decompression and complications of the initial decompression and subsequent reconstructive cranioplasty. In the early 2000s, 3 multicentric randomized control trials have been conducted with favorable outcomes in patients who underwent decompressive craniotomy for the treatment of large middle cerebral artery ischemic stroke. These studies were mainly done in Europe. We have the decompressive surgery in 2007, 2 of them were being carried out. We have the decompressive surgery for the treatment of malignant infarction of middle cerebral artery, that's the DESTINY, abbreviated DESTINY, which was conducted in Germany, and the decompressive craniotomy in middle cerebral artery infarcts, abbreviated DECIMA, was conducted in France. While another one in 2019, the Netherlands, the hemicraniectomy after middle cerebral artery infarction with life-threatening edema trial was conducted. All these different trials concluded that patients who could undergo this decompressive hemicraniectomy are patients who were under 60 years of age and who were under 60 years of age and who came before the 48 hours after onset of the stroke. So yeah, the question is asked ourselves, when should we perform our decompressive craniotomy? The answer is as early as possible if the patient have protective features. This is a level 1 CEO recommendation. As we said earlier, we have patients who are aged. This diagram is trying to resume the different indications of patients who can undergo decompressive craniotomy at their entry. First of all, we have to ensure that the patient is less than 60 years. And we have to consider comorbidities if the patient is greater than 60 or greater is 60 years or above. The surgical timing should be less than 48 hours because usually when these patients, there is no functional, there's a better functional outcome with patients who arrive, on whom the decompressive craniotomy was performed less than 48 hours after the onset of the stroke. So these are some predictive factors which determines the choice of the patient who undergo the decompressive craniotomy. We have clinical, biochemical, and the radiological parameters. For the clinical parameters, the knee score is the main determinant. That's a patient who arrives with a knee score greater than 20 for the dominant hemisphere and greater than 15 for the non-dominant hemisphere within the 6 hours. These patients should undergo decompressive craniotomy. We have also a patient who arrives with nausea, vomiting, or hyperthermia. This patient can be considered to do a hemicraniectomy. There are also some biochemical markers such as the hyperglycemia, leukocytosis, and an elevation in the protein S100B levels. These patients should be considered as considered to be highly predictive of having a malignant edema. We should note that the role of intracranial pressure monitoring in this patient is limited, as neurological deterioration can occur without an increase in intracranial pressure. As for the radiologic features, a hypodensity greater than 50% of the middle cerebral artery territory, the involvement of the anterior cerebral territory and the posterior cerebral posterior artery territory or the basal ganglia are highly predictive of a bad outcome. A midline shift on the CT scan or diffuse weighted MRI, a midline shift as well as an infarct volume greater than 145 milliliters is highly predictive of a patient who should undergo a decompressive hemicraniectomy. So on this table, I'm trying to this is the knee score. The knee score, as we talked about, the knee scale as we talked about earlier. This scale was described in 1989 by T. Burt, which helps in the as a clinical prognostic tool in the planning of revascularization treatment with recombinant tissue plasminogen activator. It is also a predictive. It also predicts the patient's outcome. This tool is made of. This scale is made of 11 points. We have the level of consciousness, the response, the best gaze on response, the visual response, the facial palsy, the presence of a facial palsy, the motor arm response, the motor leg response, the limb ataxia, sensory response, the best language, dysarthria, and extinction and inattention. A patient with a zero score, with a zero knee score, is considered to have no stroke syndrome, while a patient who is greater than, who has a knee score greater than 16 has a really bad or poor outcome, clinical outcome usually. On this second image, we have the image, a CT scan of a 54-year-old female patient who underwent a decompressive hemicraniectomy after a large impact of the middle cerebral artery. So we can see here the impact. It was really large, and we can see already the brain already herniating, and the midline shift is being reduced. We can see here how the midline shift, due to the hemicraniectomy, you can see the midline shift, which has already come back to its normal position. On this flow chart, we try to explain a little algorithm on how we choose our patients, the patients for a decompressive surgery. When a patient arrives, a thorough clinical and radiological assessment should be done. If the patient has an ischemic stroke, then we put the patient on a massive medical treatment, and we should ensure ourselves that we are less than 48 hours after stroke onset. If the if his clinical status worsens, then we have to ensure ourselves that the patient is, first of all, less than 60 years, has a fair neurological status or few comorbidities, even if he's greater than 60 years, then we can do the compressive surgery. As for posterior circulation infarcts, they usually lead to obstructive hydrocephalus or massive edema. The treatment of this obstructive hydrocephalus is ventriculostomy. This ventriculostomy should be associated with sub-occipital decompressive craniectomy in order to prevent an upward cerebellar herniation. While the massive edema we can only do the sub-occipital decompression. This is recommended except for a patient who presents himself with a lateral medullary syndrome, which is usually due to a primary brainstem ischemia. During this sub-occipital decompression, we have to enlarge the foramen magnum, and then the dura is then opened, and the infected cerebellar tissue usually exudes like toothpaste, and is easily aspirated. So we have here an image of a ventriculostomy that's on the third ventricle, and we have there an example of the sub-occipital decompressive craniectomy. You can see that the foramen magnum has to be enlarged a little bit. Finally, we finish our treatment by doing a cranioplasty. It is important to do this craniectomy because it helps to rehabilitation. It helps in rehabilitation of the patient. It restores the cerebral protection and cosmetics. And in certain patients, it also improves neurological function. This cranioplasty could be done with the bone flap that we early prelevated, that's removed, or it can be done with a synthetic flap like this made of polyether ketone, which is usually done in our country. I've never seen that, but I've already seen a craniectomy with a cranioplasty with a bone flap previously conserved under the skin, that's on the subcutaneous skin of the patient. These surgeries are usually sometimes followed by complications. Post-operative, we could have post-operative subdural or extradural complications for patients who undergo decompressive hemicraniectomies, or even we can have a syndrome of the Triphyne. This is usually a rare complication after craniectomy, where with a sunken skin above the bone defect. It is usually accompanied with neurologic symptoms such as severe headache, mental changes, focal deficit, or even seizures. As for the complication of the cranioplasty, we could have sudden death. We could also have a subdural or extracranial hematoma, and we can have also a bone flap resorption. On this slide, I try to show out what is the modified Rankin scale. It is mainly a prognostic scale on the ability or disability of a patient who has stroke. When the patient has no symptoms at all, then the functional prognostic value is good. While when the patient goes, the Rankin scale climbs, that's from no deficit to severe disability. We have a patient that is likely to have no functional recovery or difficult functional recovery. The study done by Hamlet in Netherlands in 2009 showed that patients who came, as I said earlier, on whom decompressive hemicraniectomy was carried out before 48 hours after the onset of strokes had a significant reduced probability of severe disability or death than people who came after 48 hours onset of stroke. We shall talk about the different preventive methods that are used for in acute ischemic stroke. As we said in our last presentation, there is a carotid endarterectomy, carotid angioplasty, or stenting. Usually, despite the proven effectiveness of carotid endarterectomy, carotid artery stenting has been promoted as an attractive, less invasive option for revascularization. The potential advantages of carotid artery stenting includes decreased patient discomfort and shorter recuperation period. But after the carotid revascularization endarterectomy and of a stent trial, they discovered that they had similar outcomes. So if the patient is poor, we can still do the endarterectomy. They have no problem. They have the same outcomes. Finally, patients could undergo extracranial to intracranial arterial bypass. Unlike in the carotid endarterectomy or carotid artery stenting, there is no benefit for patients with atherosclerotic carotid occlusions or carotid artery stenosis. This technique is usually beneficial for patients who have the moya-moya disease. How is it done? We use an extracranial arterial supply, usually the superficial temporal artery, which is and then we anastomose it either directly or indirectly to an intracranial cortical artery. To conclude, we say that surgical indications of anterior ischemic strokes depends on the NIS score, biological and radiological predictive values. The time to treatment is a critical factor in improvement of outcomes in these patients, and the development of additional strategies to decrease time to intervention are warranted. Decompressive hemicraniectomies for anterior circulation strokes and suboccipital craniectomies for posterior circulation strokes are valuable operations for the life-threatening consequences of malignant edema after stroke. So these were our references, our different references, and I will say thank you for your attention.
Thank you very much, Dr. Gomsi. Thank you so much. It was a good presentation. Before we move on, I guess we'll have a few comments. We can start with the consultants here, Dr. Meloni, Dr. Jimo, if you have any comments.
Let me. Hello once again.
Yes.
Nice presentation, Natalie. That's a good one.
Thank you.
It was very clear. Now, I think your topic is surgical indications for ischemic stroke. I expected you to, first of all, give a background, basic physiology, anatomy. You tell us about the circulation of the brain from the carotid, vertebral, artery, in a single or two sentences for us to have that that clear in our mind. And what you are talking about is deprivation of blood supply to the brain and the consequence or the consequences. Therefore, management of ischemia, we have to have a background knowledge of the blood supply to the brain, the cerebral blood flow. We need to know that. We need to know the normal, the abnormal, or the midpoint where things are still reversible. And we are talking about ischemia is time bound. We are talking about something must be done within a very short time. We have to know what ischemic penumbra is. So like cerebral blood flow, it has to be 50 or thereabout mils per 100 grams per minute. What ischemic penumbra is, what you have to do. These are rather a bit abstract, not surgical in the sense of it, but you need to know all that. And once it happens, what needs to be done? In most cases, is medical. Then now you have to come surgically, and that is the essence of the presentation, surgical indication of ischemic stroke. So mostly, the consequence is what you dwell on, what you are dealing on mostly, which is edema. But can you do something apart from the edema to revascularize the brain? You talked about the EC, Shanti, Moya disease. Excellent. Now, and again, we have to know what acute ischemia is and chronic ischemia. Acute ischemia, a lot of it depends on time. You have to do something medically, surgically, you have to do things, endarterectomy, or you have to remove clot from the vessels to prevent further, because this thing is time bound. 3 hours, if nothing is done, medical surgical extension, I guess you use the whole essence. Then you should have also introduced this acute ischemic stroke and chronic ischemic stroke. In chronic cases, you might be dealing with the consequences. And the consequence, stroke has taken place, the cerebral cortex has a problem and is generating problems. Let's say seizure, you have to do something. It's an indication for surgery in some instances by extension. I hope I'm not getting too deep in this matter. I guess that's the way I see this topic actually. But in essence, you've done extremely well. That's my contribution. Thank you.
Well, thank you very much.
Thank you, Dr. Jimo. But the problem is, I had already a presentation that we did where it was much more detailed, and this was just a second part. That's why I was taking an example of previously we talked about. So it was just a continuation or a completion of what I did.
Sorry, I wasn't part of that. Sorry.
Yeah,
yes.
Sure.
All right.
Thank you.
Okay, Uri, go ahead.
Yeah, thanks so much. Dr. Meloni, do you have anything you want to add maybe?
Well, I totally agree with Dr. Abdullah. It was a very well done presentation, Natalie. I appreciate a lot how do you highlight the surgical indication for the compressive craniectomy, because not in all patients the compressive craniectomy create a good outcome for the patients. When the patient is in a neurological status that is going more and more worsening, the compressive craniectomy sometimes is successful. You just you don't get any good outcome, but just a vegetable status is not good at all. So I appreciate a lot of that. Thank you.
Thank you, Dr. Marco.
Thanks. So obviously really good presentation. I think I would like us to discuss a bit about the last time the patient was seen as being well, and what are the different strategies or managements we can propose. If you want to contribute, and obviously given our context, maybe make it more specific to our context, because it's a bit of an issue, I guess, because we've had endovascular techniques at one point. We've had pharmaceutical treatments, and then at one point in time, it's like, oh, that's not the best. Let's go back to this. So it's changing a bit. Just your point of view on that.
Yeah, of course, we need to highlight, Ulrich, that this stroke is a multidisciplinary topics that involve endovascular, involve neurologists, involve neuro anesthesiologists, and neurosurgery, of course.
Okay. Yeah, Dr. Kavulo, Dr. Jimo, do you have anything you'd like to say about this? The different management options available, perhaps for stroke management in low and middle income countries, and maybe even the prognostic. I guess in that case, it's a bit difficult to have those to decide how to take care of these patients.
Oh yes, just like what Dr. Maloney said, it's a multidisciplinary approach that we use in managing patients with ischemic stroke. Now, when the patient comes around, well, it has to be a setting where people are alive to their responsibilities. You see, and the outcome depends on the training of every aspect of this multidisciplinary team. Now, the first caregivers, like where ambulance exists, and of course in low income countries, some of these things don't exist. First of all, it happens at home. The patient is discovered by relations somewhere not behaving how he's supposed to behave, or is unconscious. First of all, people will run around, shout, later get the patient. Mode of transportation to the hospital is difficult, and what you meet in the hospital is a bit not ideal. Okay, so since this thing is time, we all depend on time in this matter, we are losing time. And as the patient goes into the hospital, there are criteria, actually, inclusion and exclusion criteria, and even doing the first thing to the patient. First, you are supposed to know what the problem is. Is it stroke itself? Is it severe hypertension only? Is it hyperglycemia, hypoglycemia? Is it any other thing, a gamut of other things that could be happening? We don't have the tools to immediately know what the problem is. You have to do brain imaging, initial blood tests to know what the clotting issues are, because you can't even do certain basic things until you know what the basic level is. You have to know the clotting. Assuming from your clinical history, you have the suggestion that, of course, this could be stroke, ischemic, hemorrhagic, or okay, you say it's ischemic stroke, commonest. Now, what do you do next? You need an image, because you can't give blood thinners without having an image, because it could be hemorrhagic and you can't compound the patient's situation. With all these things, you are losing time. So if the diagnosis is made, basically, first thing is medical treatment. Do you give hypoglycemic if the anti-hypoglycemic agent if the blood sugar is high? Do you give how much you bring the blood pressure down if the blood pressure is high? which is common in with ischemic strokes. You do an image. There bleeding, there is none. Is there edema, which Dr. Natalie expressed on mostly? If there is, of course, ischemic stroke, what type do you give in our setting? Which one is available? They could be expensive. How much do you give? Is it a general thing? There are inclusion criteria for giving blood thinner. If not, you could compound the patient's problem. A lot of procedures in the past, the history, which must be very, very clear. And in our setting, the provider or the person that is bringing the patient might not have a good record of what the patient is or has been taking, or has not been using that medical setup. So there are no records. So it brings a lot of problems. Now, if all medical aspects are explored, and in this instance, the multidisciplinary team, everybody must be around, the anesthetists, the neurologists, the surgeon, the cardiologist, the cardiac surgeon, depending on what we want eventually. If this surgical aspect is indicated, it means endovascular form of treatment or selective vessel infusion of anti or thrombolytic agent. These ones, all I'm talking about, are not clearly available in our setting. However, we try to, in the interim, do much to see how much we can keep the patient on. That is for acute edema. As a neurosurgeon, what is when there is massive edema, decompress, and that one will remove the risk of edema that will further cause herniation and further cause problem. And that is what Natalie stressed upon, which is fantastic. That's the first thing that's the stage we are now. Then the next is, as in the ischemia is chronic, it still has surgical indication because there's consequence on the patient. Dysplastic cortical area that is generating a seizure always, that's another extension of management of ischemic stroke. That's in summary what I have to say. Correct.
Well, thank you so much. So there's you've raised a lot of points about the difficulties in managing these patients in low and middle income countries, and obviously our next question would be, what do we do next? Like, strokes are getting more and more common with the change in the burden of diseases, and we will be seeing more and more of these cases. So
yeah,
the management, like what can we do to better manage these patients?
Now, there are two aspects to it. One to the general populace, and the second one to the doctors. To the general populace, you have to prevent it, because even in the developed economy, is one of the leading causes of serious mortality and morbidity. So the first thing is we have to prevent it by health education. We have to reach out. We have to advocacy group, a kind of, if possible, multi-country, multi-center, the various stroke groups or societies in various countries will have to be advised or mandated, actually further advised, because they know already, to have advocacy group actually to prevent this thing. How do you prevent it? Is basically the underlying problem, the high blood pressure, the hyperglycemia, not well managed. All those things must be prevented. Health education to prevent all this. And then secondly, to the doctors, what we're doing now is continuous education. We are enlightening ourselves what to do. That's the essence of what we are talking about, actually. Apart from the education, it's also on how to better the care of your patient. So these are the two prongs I see we have to pursue to reduce the burden of this disease. Health education, we have to know the first thing first, just like A, B, C, D. Okay? And that's the essence of this presentation. What do you do? Medically, surgically, and all other disciplines of medicine to make sure the patient who has suffered stroke has a better outcome in terms of less mortality and less morbidity.
Thank you so much.
If I can add just one thing, Ulrich, another thing is necessary to do to improve the outcome, to improve the patient assistance is the centralized stroke unit.
Yes.
I don't know how is the situation in your countries, but I have experience of some center when the patients came, there is need indication for thrombectomy because there is a thrombus in the M1, but there is no endovascular, so the patient need to be moved in another hospital, or there is need for the compulsory craniotomy, there is no neurosurgical unit. So is as just highlight to Dr. Abdullah, is a loss of time, and remember that time is brain.
Yes, yes. Thank you so much. I mean, there's so that there are a few options, a few technologies I've come across here at the Brigham, and I think they could actually be amazing for low and middle income countries, but that they're having difficulties establishing them here because of so the first one is there's this application that has been developed by a few neurosurgeons here and people at MIT, and the application does what it does is it uses artificial intelligence to once a patient gets a CT scan, immediately as he gets a CT scan, it gives a presumptive diagnosis of, say, for example, a stroke, a subarachnoid hemorrhage. And once it does that, it sends the images and a message to all the members of the stroke unit, for example. So if you're a neurosurgeon, before the patient even leaves the imaging or the radiology unit, before he leaves, you already have a message and you already have the image. That tells you already, okay, we can start preparing. So even the guys at the OR already have the information saying there's a patient coming, we have to prepare, because those are the things we have. We lose a lot of time in developing countries. You get a patient before the guys from radiology tell you it's a stroke, it's 2 hours before the guys at the OR are ready for you to come in, it's maybe 3 hours. And they're having a lot of difficulties using it here because the regulations are really strict. The HIPAA regulations for patient information protection. And I was wondering, this is something that if we can, not necessarily the same thing, but this is something that can work in developing countries, because if we have a centralized unit, for example, I'm thinking maybe in one of the capitals and a patient gets a CT scan in another city, then they already know they're getting that patient. And I think that's one of the ways you can reduce it. Obviously, there's prevention as well. Definitely, there's definitely prevention that we have to do. And I think we as future neurosurgeons, as young neurosurgeons, as consultants, have to start thinking about these solutions beyond just the operative act. Like if we need apps, we need to be working to develop apps. If we need different communications, then we need to do them. We have to do these things. Otherwise, we'll just find ourselves with a whole lot of people just having strokes left, right, and center, or trauma, and we wouldn't know what to do about it.
Yeah, Ulrich, I'm right, but I think also that we should increase our workforce. Like in Cameroon, for example, I think there are neurosurgeons maybe in something like 4 or 5 cities. 5 cities in Cameroon, and really the workforce is really low. So in fact, there are so much problems. There are problems of transport. When are they diagnosing? When are they doing the diagnostic? When are they going to send the patient? How would they send the patient? It is really, and usually, in our countries, for being in Ascovim, for going to our villages, we don't have network. They don't usually have no, they don't even have treatment. Even those medical treatment that we say we are talking, I've never seen the recombinant tissue plasminogen activator. I've never seen it.
Yes.
Since I've started school till date, I've never seen it. So we really have issues where I think we should really include stroke management in the universal health coverage of our countries.
Yes.
That these drugs become more and more frequent for patients or medical doctors to use. So
Absolutely. You're absolutely right. And I mean, this is why I'm saying neurosurgeons need to go beyond just neurosurgery. When you speak about the problem with the network, for example, there's things like messages, simple SMS text messages, which go through USSD. You might not have internet, but you can get USSD. And then that means neurosurgeons need to be with the guys who develop these applications and tell them, okay, use this, and this is what we want. This is the least information we want, for example. We want the Glasgow, but that will mean, okay, if we're training people at medical schools, we need to teach them, even if you're going to be a general practitioner working somewhere remote, the least you can give me, for example, is the Glasgow. I expect you to send me maybe a message, tell me what are the symptoms, and this. But anyway, we need to develop this. We need to brainstorm on these things, and we need to come up with solutions. I think that was an amazing presentation. It's always great to have these thoughts flying around. We can go on to the next presentation by Arsene Daniel Nyalunja. So before he starts, we're going to start another round of presentations, and then we'll have him start. So hello everyone, I'm Ulrich Sidney, the president of the Association of Future African Neurosurgeons. I am a research associate at Program Global Surgery, Harvard Medical School. And today we're having a second presentation for the day, which is a continuation from a first presentation. This is the acute decompression of the facial nerve. Arsene first of all presented acute decompression of the optic nerve. That was a few weeks back, and he's back with this other presentation. We're looking forward to it. But before we start, we're going to have the panelists present themselves. We'll start with Dr. Marco Meloni. Hello, Dr. Marco.
Hello, everybody. My name is Marco Meloni. I'm a consultant neurosurgeon in Gravedona, North Italy. Hello, everybody again.
Hi, nice to meet you. Dr. Abdullahi Jimo.
Hello, everyone. My name is Abdullahi Onimisi Jimo. I'm a consultant with the Ahmadu Bello University, teaching hospital in northern Nigeria. I'm currently in Morocco doing a fellowship in stereotaxy, gamma knife, and functional neurosurgery. Thank you for having me here.
Thank you for being around. We always appreciate having a consultant neurosurgeons with us. The next one will be Dr. Natalie Gomsi.
Hello everyone, I'm Natalie Gomsi. I'm a PGA1 neurosurgery resident in the Ivory Coast, Abidjan. And it's really nice to meet you. And Happy New Year to everyone.
Happy New Year, thank you so much. Next up is Dr. Leo Yanu. Hello, Dr. Leo.
Hello again to everybody. My name is Leo Yanu. I'm a medical doctor from Cameroon, and I'm a general practitioner.
Nice to have you. Nice to have you. Thank you so much. Derwin Sishimba. Hello. Hello, Derwin. Unmute yourself, please. Darwin, we can't hear you. You're muted.
Hello.
Yeah.
Hello.
Hello.
Okay, I'm Darwin Chimba, medical student from Zambia. Mm-hmm. I'm so happy to be here. It's been a while.
It's been a while, Darwin. Happy New Year to you.
Thank you so much. Happy New Year to you too.
Igor Nicher, if you can unmute yourself and present. Yes.
Hello, everyone. My name is Nicher Igor. I'm from Cameroon. I'm in second year resident neurosurgery in Abidjan, in Ivory Coast. I'm happy to be here.
Happy to have you as well. Dr. Aminata Salah, are you around? If you're around, you can unmute yourself and present yourself. I think not. Okay. Please, guys, everyone mute your microphones. We're about to start with the next presentation. So Arsene Daniel can present himself and start the presentation. Happy to have you. You're muted, Arsene. You're muted.
Okay, I'm here. Hello, everyone. I'm Arsene Daniel from Republic Democratic of Congo. I'm a medical student in the final year. I'm going to present the acute bone decompression of the facial nerve. Before starting this presentation, I would like to wish to everybody a happy New Year. And I would like also to apologize myself for the delay. According to this presentation, we are going to have two main parts. The first one,
Asen, there seems to be a problem with your mic. So maybe if you you can take it off maybe and just use the normal mic because we have difficulties hearing. Is that okay?
Okay, let me try.
Yeah, don't worry. We'll edit this out. Osheen, can you hear us?
Yeah, I'm here, Dr. John.
Okay.
So do you hear me?
Ulrich, you're sharing the screen, right? Daniel's not, right?
Yes, I'm sharing the screen.
Okay, because someone's sharing the screen, and I don't know what's happening there.
I'm the one sharing the screen.
Yeah.
Yes, Daniel, you can go ahead.
Do you hear me?
Yes, perfect.
Ulrich, you need to minimize. We're seeing half the picture, half the presentation. Since you're okay. I'm sorry. It's me. I'm sorry. Go ahead.
Okay, let's go ahead.
Okay, anytime you're ready.
Okay, as I said already, we are going to discuss about the acute bony decompression of the facial nerve. And during the presentation, we will make an overview on the facial nerve paralysis, and we will discuss the anatomy of the seventh cranial nerve, the etiology of the facial palsy, the pathophysiology of the facial nerve injury, with special emphasis on the pathophysiology of the temporal bone fractures. And then it will be followed by evaluation of the facial paralysis, the imaging assessment, and the management of the post-traumatic nerve injury. And if you allow me, I will conclude this presentation by highlighting the essential points of this interesting
Hello, Asen. Maybe we lost him.
Let me check here.
Maybe we lost him. He might have to.
Yeah, I think he may have dropped off, but he'll come back, I'm sure.
Yeah.
No, he's still here. You can hear us, Arsene?
His video is there, so he's still, and
he's still logged in.
Yeah, he probably needs to cut out the video.
Okay.
Yeah,
okay.
He's back. He's back.
Okay.
Don't forget to cut the video, please, Asen, so we
to
can
the first slide. Yeah. Okay. Come back to the first slide, please.
Okay. Yes.
And now the next one.
Okay.
Okay. Because speech and mastication, expression of mood and emotion are based on the ability to move the facial musculature, be it voluntary, successful treatment of the facial nerve paralysis is a vital concern. According to a medical dictionary, the facial paralysis is a relatively common condition in which the facial nerve ceases to innervate in several branches in the face. If one or more of the facial nerve branches are paralyzed, the corresponding mimic muscle loses their ability to contract. And this may lead to several symptoms such as incomplete eye closure with or without exposure keratitis. Can lead also to the oral incompetence, to a poor articulation, to a dental caries, a drooling, or a low self-esteem. The facial paralysis is in children is an uncommon condition, although it is common in adults. And in 2018, it was estimated annual incidence is thought to be approximately 2.7 in 100,000 children younger than 10 years. And in the global population, it accounts approximately 20 in 100 people who are diagnosed yearly with the facial paralysis. The etiology of facial nerve paralysis can be attributed to various causes, and this etiology can be categorized in etiologic at birth, in which we listed molding, forceps delivery, dystrophia, and the Mobius syndrome. We can also another category, which is the trauma with a basal skull fracture, the facial injuries, with a penetrating injury to the middle area with scuba diving, which is a kind of barrow trauma. We can have also some neurologic etiology in which we can elicit an orbicular syndrome. We can also have some metabolic etiology in which we can have diabetes mellitus, we can have hypertension, we can have acute porphyria, we can have some idiopathic etiology like a autoimmune syndrome, like a Bell's familial. We can have some other etiology which are iatrogenic in cases of mandibular block anesthesia, in case of post-immunization, in case of mastoid surgery. We can list some infectious etiology like an external otitis, like otitis media, like influenza, like malaria, like tuberculosis. We can have also some neoplastic etiology like cholesteatoma, like the 7 nerve tumor, like a leukemia, like meningomia. At the end, we have the last categorized is a toxic etiology with the ethylene glycol, which alcoholism, which intoxication to arsenic in case of tetanus. And in spite of the statistic above, there are several described causes of the facial nerve paralysis in children in approximately 40 up to 75% of cases, and the cause of unilateral facial palsy is still unknown and it remains idiopathic. The post-traumatic nerve injury has been described in 2% of all head injury and is the second leading cause of the facial paralysis in adults. And among the patients with skull fractures, 14 up to 22% have a temporal bone fractures, which can result in aerial loss in cerebral fistula, in cerebrospinal fluid fistula, and in a facial nerve palsy. When the facial nerve palsy is associated to the temporal bone fracture, it can be divided into immediate and delayed facial palsy. An immediate facial nerve paralysis, which are associated with an extratemporal facial nerve trauma, should be repaired in the 72 hours of the injury, and it accounts for 1.5% against 0 points up to 2.2 for the delay onset facial palsy. And patients with delay onset facial paralysis are generally believed to have a better prognosis regardless of management than those with immediate nerve dysfunction, although this has been challenged. Evaluation in patients with extreme head trauma or the facial injury is often difficult because of the severity of the injury or the trauma. The evaluation must include through 3 important factors: the facial duration, the location, and the mechanism, with a precise characterization of the facial nerve paralysis, which must be accomplished in order to provide a proper patient counseling regarding the prognosis and the treatment. The surgical management of the facial paralysis requires the reconstructive surgeon to apply a wide spectrum of reconstructive and aesthetic principles using a comprehensive array of surgical tools, including microsurgery, peripheral nerve surgery, and aesthetic facial surgery in order to optimize the patient's outcome. And the treatment of the injured intratemporal facial nerve is historically controversial. Is important to note that reanimation in facial paralyzed face is an interesting and frequently evolving field. And most authors advocate for an early operation in temporal bone fractures with a total facial paralysis and radiographic evidence of the facial canal discontinuity or the facial paralysis satisfying electrodiagnosis criteria after 3 days. And certain authors are favoring for a more conservative approach. And in general, the decision to operate is depending on the site of the injury, the time curve of the facial palsy, the radiographic evidence, and the electrodiagnosis criteria. Just the technique of the extent of the facial nerve decompression is dependent on the site of the lesion and the patient level of erring. It is important to note that a good appreciation of the anatomy of the facial nerve and the temporal bone allows localization of the lesion and aid in the selection of the appropriate management. According to the anatomy of the facial nerve, which is the second point, it mentioned previously, an appreciation of the anatomy of the facial nerve and the temporal bone allow a localization of the lesion and aid in the selection of the appropriate management. The facial nerve or the seventh cranial nerve is the nerve of the facial expression, and the pathway of the facial nerve are variable, and the knowledge of the temporal and extratemporal landmarks is essential for an accurate physical diagnosis and safe, effective surgical intervention in the head and the neck. The facial nerve is composed by approximately 10,000 neurons, in which 7,000 of which are myelinated and innervate the nerve of the facial expression. 3,000 of the nerve fiber are somatosensory and secretomotor and make up the nervous intermediates. This nerve is predominantly motor nerve that innervate the muscle of the facial expression and the muscle of the scalp and ear, as well as the bicinator, the platysma, the stapedius, the styloid, and the posterior bell of the gastric. In addition, it carries parasympathetic secretory fiber to the submandibular and sublingual salivatory gland, the lacrimal gland, and to the mucous membrane of the oral and the nasal cavities. The facial nerve has some sensory functions, and the most important of this sensory function is to immediate the taste from the anterior 2/3 of the tongue. It also conveys extroceptive sensation from the eardrum and the external auditory canal. It has also a proprioceptive sensation from the muscle it supplies and the general visceral sensation from the salivary glands and the mucosa of the nose and the pharynx. Anatomically, the motor division of the nerve is separate from the sensory and the parasympathetic portion, and as we said, the anatomic motor division of the nerve is separate from the sensory and the parasympathetic portion. In its case, the nerve exits from the bone until its terminal arborization, and several important branches are given off in the following order. We have the greater or the superficial petrosal nerve. We have the nerve to the stapedius and the choroidal tympani. The nerve may be understood as a series of segments in which we have a brain of intermediate intramedullary segment, which come from the brainstem nuclei to the exit point. We have also a segment from the exit point to the exit point to the entrance into the internal auditory canal, or which is also called the cisternal segment. We have a meatal or a canal segment which goes to the internal auditory canal, to the entrance to the facial canal. We have a labyrinthine segment from there to the geniculate ganglion. We have a short horizontal segment which grows from the geniculate ganglion to the pyramidal eminence of the posterior wall of the tympanic cavity. We have also a mastoid segment from the pyramidal eminence to the stylomastoid foramen, and at last we have an extratemporal or peripheral segment which grows from the stylomastoid foramen to the pes anterius. The cause of the facial nerve and its central connection can be roughly divided into the segments which are related in this table. As we said, we have a supranuclear segment which is located in the cerebral cortex. We have a brain stem which is located from the motor nucleus of the facial nerve to the superior salivatory nucleus of the tractus solitari. We have a meatal segment which located in the brainstem to the internal acoustic meatus or the canal. We have also a labyrinthine segment which is located in the fundus to the facial hiatus. We have also a tympanic segment, a mastoid segment, and extra temporal segment. The associated finding in a cranial nerve in a seven cranial nerve palsy often allow identification of the involved segment of this nerve. And the motor portion of the facial nerve, we have some axon of the facial nerve which arise from the dorsal surface of the nucleus and travel dorsomedially, moving up and around to the encyclical to the abducens nucleus, forming the internal genome of the facial nerve. We have also the internal lobes of the seven cranial nerve fibers around the sixth cranial nucleus from the facial colliculus, which is a bump in the rhomboid fossa in the floor of the fourth ventricle, which is a prominent landmark for surgeons who are working in this area. The facial nerve, as we said already, two components, which one is the motor, which are make up about the 70% of the fibers, and the sensory roots. We have also the sensory roots which account for 30% of the fiber of this nerve. And the sensory root from the nervous intermediates of Risberg and contain both sensory and automatic fibers. The automatic fibers run near the incoming sensory fibers through the pons. We have the intrapodial filament of the seventh cranial nerve. Thus consists of existing brachiomotor and parasympathetic fibers and incoming sensory fibers. On this image, we saw the cranial segment which extends from the pons lateral to the frontomedullary junction, just caudal to the root of the fifth cranial nerve between the olive and inferior cerebral peduncles. Next slide. The nervous intermedius is a small bundle that usually leaves the pons closer to the 18 cranial nerve than the 7 cranial nerve and run between the larger trunk across the cerebellopontine angle, which is right here as shown on this image. At the entrance of the internal auditory canal, the facial nerve motor root lies in a groove of the anterior superior surface of the vestibular cochlear nerve, with the nerve intermedius in between. And this segment, the cranial nerve, the facial nerve is a paler color white than the 18th cranial nerve. The facial nerve at this point lie in a close proximity to the anterior inferior cerebral artery, and in some individuals, the anterior inferior cerebral artery loops down into the internal auditory canal, as with the vaginal sheaths of the optic nerve, the subarachnoid space extends along the facial nerve to the geniculate ganglion. At the bottom or the lateral end of the internal auditory canal. The nerve pierces the meninge and enter the fascial canal of the fallopian aqueduct. The point of this entry is the narrowest portion of the canal. The fascial nerve and the nervous intermediaries merge as the nerve enters the canal. In traversing the fascial canal, the nerve makes two abrupt tortuous turns, creating two external journeys. In it goes through the petrous bone from its entrance into the fascial canal until it exits from the styloid mastoid foramen. The nerve has three segments, as we listed already, with a labyrinthine segment, an horizontal or the tympanic segment, and the mastoid or the vertical segment. The labyrinthine segments lie laterally between the cochlea and the vestibular trochanter, the medial wall of the tympanic cavity, running perpendicularly to the long axis of the petrous pyramid, and the labyrinthine segment which end at the first external gene where the geniculate ganglions lie. And it is important to know that at this point, the nerve turns abruptly and run horizontally from about 1 centimeters, and then turn backward and arc down behind the tympanic cavity, which is the mastoid or the vertical segment. And the branch to the stapedius muscle arise from the distal tympanic or the upper end of the mastoid segment. At the end of the tympanic segment, the nerve encounters the second external genius as it makes a 90-degree turn to the outer of the mastoid segment, and the mastoid segment descend toward the stylomastoid foramen and give off the choroida tympani about 6 centimeters before it exits and emerges from the stylomastoid foramen. There may be an anatomical variation in the nerve course through the petrous bone. It may split into 2 or 3 stand or the distal geniculate ganglion. The more proximal division into the strand, the more bizarre the subsequent scars. The fascial motor fiber may run in some enlarged choroida tympani, diminishing the distal fascial nerve into a tenus stranding exciting through a narrowest stylomastoid foramen. Just after I excite the posterior auricular, the gastric and styloid branches arise. The posterior auricular branch supplies the occipitalis, the posterior auricularis, and the transverse and the oblique auricular muscle. It is important to note that the gastric and the styloid branches supply respectively the posterior belly of the gastric and the styloid mastoid. The nerve at this point turn forward and pass into the parotid gland within the substance to the parotid, and it divided into a temporal fascial and a cervical division at the pes anterius, which is the intraparotid plexus, enclaved between the superficial and the deep lobe of the gland. The temporal fascial branches grow the zygomatic about 1 centimeter anterior to the ear, where it is vulnerable to injury, and the fascial nerve supplies all muscle of the fascial expression from the scalp and the forehead through the platysma, including the extrinsic and intrinsic muscle of the ear. The muscle of the fascial expression are responsible for all the voluntary and involuntary movement of the face, except those associated with movement of the jaws, and for all play of immersion upon the face. Here we have some division of the branches and the muscle action. We have the first nerve branch, which is a temporal branch, which innervates the frontalis muscle, the corrugator, the upper, and the occipitalis, also with the processories, which is the pyramidal rise. From the frontalis, the muscle action, which is to raise eyebrows and skin over the rods of the nose, to draw scalp forward and turning the forehead into a transverse rectus. We have the corrugator or the corrugator superficialis, which draw the eyebrow down and medially produce a vertical wrinkles in the forehead. We have also the upper part of the orbicularis oculis, which the action is the eyelid sphincter, the palpebral portion narrows, the palpebral fracture of the gentle closed eye, and the orbital portion around the skin of the forehead. For the zygomatic branch, which supply the lower and the lateral orbicularis oculis, the muscle action is the eyelid sphincter. We have also a buccal branch which innervates the orbicularis oculis, the buccinator, the zygomaticus, the nasalis with the compressor nerve, the levator angulis ori or the canis. We have also this branch which innervates the levator labialis superioris, which is the quadratus labialis superioris. For the orbicularis oculis, as we said already, the muscle action is the eyelid sphincter. The buccinator, the muscle action is the compressed checks, keep food under pressure of checking in chewing. For the zygomaticus is to draw mouth backward and upward. For the nasalis compressor is to depress cartilaginous portion of the nose and draw the ala forward the septum. For the mandibular branch of the facial nerve, it innervates the lower part of the orbicularis orelis with a muscle action which is the sphincter of the mouth to close the lips, superficial figure profile the lips, and deeper figure draw lips in and press them against the teeth. We have also a mandibulis nerve, which are also innervated by the mandibular branch. The muscle action is to protrude lower lips to wrinkle skin of the chin. For the cervical branches which innervate the platysma, the muscle action is to pull lower lips and angle of the mouth down to depress lower jaw, to raise and to wrinkle the skin neck. So for now we are going to talk about the nervous intermediates. As we saw, the nervous intermediates is a sensory and automatic component of the facial nerve, which run in a position immediate between the cranial nerve 7th and the cranial nerve 18 across the cerebral pointing angle, moving ever closer than the main facial nerve trunk as it is under the facial canal. At the external journey, the nerve intermedius fills with the geniculate ganglion, and the sensory cell located in the geniculate ganglion are generally somatic afferent and special visceral afferent. The general somatic afferent fibers carry exteroceptive impulse from the region of the external auditory and the canal tympanic. According to the cars of the branch of the facial nerve, the first branch given off in the facial nerve cars is the greater, so is the superficial petrosal nerve, which cut the preganglionic parasympathetic fibers, as shown on this image. These fibers are conveyed by the nervous intermedius in the geniculate ganglion. They pass through the ganglion without the synapsing into the greater petrosal nerve, which goes forward through the hiatus of the facial canal to join the deep petrosal nerve from the carotid tympanic plexus from the Bayesian nerve, or the nerve of the pterygoid canal, which run to the sphenopalatine ganglion, from where the postganglionic fiber proceeds to the lacrimal gland. The distal of the geniculate ganglion for the facial nerve continue to descend as above the nerve to the stapedius arise from the distal tympanic or the upper mastoid segment and pass through a small canal to reach the muscle. Although there is some variability, the choroidal tympani usually leaves the main trunk slightly above the slomastoid foramen. Its carotids and general visceral afferent fibers, as well as the preganglionic parasympathetic, and it runs forward and upward in a munite canal in the posterior wall of the tympanic cavity, occurs a mucous membrane investment, and then outer and crosses the middle ear. It is sometimes visible as a small white cord behind the tympanic membrane on otoscopic examination, and the choroida tympani run downward and forward to exit the skull and join the lingual nerve and the branches of the mandibular division of the cranial fifth nerve on its posterior borders. Yeah. And the fibers carrying this somatosensory afferent in the choroida tympani, who have their cell body in the geniculate ganglion, and the peripheral processes innervate the part of the external auditory canal, the tympanic membrane, the lateral surface of the pinna, and the small area behind the ear and over the mastoid process. Now there is a marked individual variation in the distribution. It is important to note that the central process terminates in the spinal tract, and the nucleus of the trigeminal and the central connection are identical with those of the trigeminal nerves. The cranial nerve 7, the facial nerve, may also suffered deep pain and deep pressure from the face. The taste sensation from the anterior two-thirds of the tongue is carried through the lingual nerve to the choroida tympani, the geniculate ganglion, and this nerve may also carry taste sensation from the mucosa of the soft palate through the sphenopalatine ganglion. It's also important to note that the central processes carrying the taste and the general visceral afferent sensation terminate in the nucleus of the solitary tract, and the solitary tract sends communication to the superior and the inferior salivatory nuclei, which send the parasympathetic to the salivatory gland. The other fibers snaps in the reticular formation next oral neuron from a component of the reticulospinal tract bilateral to the snap, which sympathetic neuron in the intermediolateral gray column of the upper thoracic spinal cord. This sends sympathetic innervation via the superior cervical ganglion to the salivatory ganglion, and the fibers surviving taste sensation ascended with the contralateral medial. Next slide, please. The extratemporal facial branches, as we listed previously, the temporal, the dichomatic, the buccal, the marginal, mandibular, and the cervical branches are shown on this image. And the facial nerve branch generally innervate to the facial muscle, with the exception of the levator angulis ouluris, the bicinators, and the mentalis muscles. Now we are going to discuss about the pathophysiology of the facial nerve injury. And the injury of the facial nerve near the geniculate ganglion was first reported in 1926 by Ulrich, with subsequent clinical studies support this observation that this represents the most frequent site of the facial nerve injury in the temporal bone trauma. And the fracture of the temporal bone tend to occur along the points of weakness, such as the foramina and the parallel to the traumatic force. The temporal bone fracture are classically described as longitudinal or transverse fractures in relationship to the long axis of the petrous pyramid. However, this scheme is given way to a new classification based on the involvement of the otic capsule, which is the bone encasing the cochlea and the semicircular canal. And the fracture that spread the otic capsule are typically due to trauma in the temporal region. These fractures tend to result in a mixed or a conductive earring loss and a lower rate of the facial paralysis. The otic capsule disrupting fracture generally results from trauma to the occiput and are associated with a sensory neural earring loss and an increased risk of cerebrospinal fluid fistula, meningitis, and the facial nerve palsy. There are some authors like Yanagihara who reported a fracture involving the geniculate ganglion in 55% of patients with a facial palsy following a neck trauma. And some authors like Fitch and Elson reported a 93% incidence of intraoperative pathology in the labyrinthine segment, and they include the geniculate ganglion with a second, less frequent focus on the descending tympanic segment. The labyrinthine segment is a pivotal to the facial nerve injury because of its small diameters, the constructing arachnoid band, and limited epinerium. As a result, any edema quickly used up the little residual extraneural canicular space. This is hypothesized to decrease the nerve perfusion, which in turn causes the more edema and setting off the downward spiral. The histopathology of the facial nerve secondary to the temporal bone fracture has been described, and the findings are consistent with those seen in others injury to a proximal neural segment. It means that the microdistal the degeneration, disorganized nerve bundles, and the Schwann cell proliferation proximally and distally. The loss of myelination in the geniculate ganglion with loss of ganglion cells and fibrosis in the perineurium and the endoneurium has been described along with the severe degeneration of the nerve fibers and fibrosis extending into the tympanic and the mastoid portion of the facial nerve. In the immediate onset of the facial nerve palsy after trauma, the nerve is either completely lacerated or contused at the fracture site. The delayed presentation of the facial palsy is seen typically between the first and the 10th day after the injury. In some patients with facial palsy developed it over 6 days after the injury trauma. But it's important to note that there are some difference ratio about post-traumatic delayed facial palsy in different studies. And Turner, who found a 2.2% ratio in their studies, while the Van Duran and all found the ratio to be up to 0.3. To our knowledge, there is no study in the literature about the issue in children, but the pathophysiology of post-traumatic delayed facial palsy is not clear and known. Some theories have been suggested about the issue in the facial canal. The area occupied by the facial nerve is only third up to 50% of the cross-sectional area of the canal. The remainder of the facial canal is occupied by the blood vessel with the connective tissue loosely arranged around the nerve. A delayed facial palsy is possibly to result from a bleeding into the facial canal and an increasing size of a hematoma in a limited non-expanding bony tube could press on the facial nerve. If the pressure were of a middle degree, there will only be a neuropraxia or a conductive block due to the segmental demyelination. If the damage were more severe, there could be an axonal damage with the denervation. The other theory is that ultimately the blood supply of the facial nerve is cut off due to the trauma, and this causes ischemic damage which can be severe. Some authors postulate a similar mechanism for this facial weakness as in Bell's palsy, with a possible inflammatory reaction in and around the nerve, or a swelling of the nerve in the canal, which could lead to the ischemic. The vascular damage, such as a delayed arterial spasm, an arterial or venous thrombosis, and external compression from bone fragments, or from soft tissue edema, are other etiological causes of the fascial palsy. Now we are going to discuss about the two types of the temporal bone fracture, which is the longitudinal bone fracture, which is seen on the left, on the versus transverse fracture on the right. The temporal bone fracture, as we said, are classified as longitudinal and longitudinal, transverse, and mixed with the respect of the long axis of the petrous bone. And in longitudinal fracture, the fracture line is parallel to the long axis of the petrous bone. And it's important to know that in transverse fracture, the fracture line crosses the long axis of the petrous bone. And in mixed fracture, there are both fractures line. Up to 18% of all temporal bone fractures are longitudinal, as well seen in the some literature. The longitudinal fracture very often pass through the external auditory canal, and the fascial palsy occur in 10 up to 20% of cases. The transverse fracture are uncommon and account for only 15% of the temporal bone fractures. And the patient who have this kind of fractures, the trauma usually occurs in the occipital and the frontal region. It's important to know that the fascial nerve palsy occurs in 50% of the transverse fracture, and the palsy is likely to be immediate of one set. In the type of mixed type fracture, there are which are very rare, and they account for up to 5% of all bone temporal fracture. The severity of head trauma affect both the severity of temporal bone fracture and the development of the fascial palsy. And presently, the use of seat belt and more recently airbag has dramatically decreased the incidence of the temporal bone fracture. According to the evaluation of the fascial nerve injury, in the evaluation of the fascial nerve injury, it is important to document that the time of the onset, the site of injury, and the degree of the functional deficit. Determining palsy duration and degree of function before injury is very crucial. Duration may be divided according to the duration. The fascial palsy can be divided into three rather distinct periods. The acute period, which go to the day of the injury up to 7 hours. We have a subacute period which run from 72 hours up to 12 or 18 months. We have a long-standing fascial palsy which is beyond 18 months. The distinction between the acute and subacute fascial paralysis somewhat is undefined. And although stimulation of the distal branches is feasible after 7 hours, the acute period, because of the Wallerian degeneration and management of which can be similarly in both periods, and which are based on the premise of the mimetic muscle salvability. According to the acute paralysis, within the first 24 hours, which suggests a more severe injury, the mechanical disruption by stretching, tearing, or shearing of the nerve, and which is associated with a poor prognosis for a spontaneous recovery. Delayed paralysis, which can develop up to 2 weeks following injury, is secondary to compressive edema or hemorrhage within the fallopian canal, and is generally felt to carry a better prognosis for spontaneous recovery. As we said, to precise calculation of the fascial nerve paralysis must be accomplished to provide a proper patient counseling regarding prognosis and treatment. Here we are going to show which a scale which called the Haus-Brackmann 6-point scale for the facial nerve function, which is most commonly used as a standardized tool for assessing the degree of the facial weakness. The next slide, please, Arik. The Haus-Brackmann facial nerve grading system is widely used to characterize the degree of the facial palsy. In this scale, which grade 1 assigned to the normal function and grade 6 represent the complete paralysis. We have some intermediate grades which vary according to the function at the rest and with the effort. So then the next slide. To the slide on the Haus-Brackmann facial nerve grading system. Okay, we have 6 grade LVCL, the normal grade, the middle dysfunction, the moderate dysfunction, the moderately severe dysfunction, a severe dysfunction, a total paralysis, with certain characterization of each grade on this table. It is important to note that this scale is deficient. However, in terms of characterizing facial paralysis, localize it to the one particular facial distribution. We have but some other scales, including the psoriasis Norwa, Barres fish, or the Nottingham and the Sunnybrook scale, which can also help in order to grade the facial palsy. Careful assessment and documentation of the facial nerve function should be include a detailed description of the status of motion of the upper, middle, and lower face. Special attention should be paid to the eye, not only in terms of the eyelid closure, the lower lid laxity, and the brow edge, but also to the visual acuity, the presence of Bell phenomenon, and the corneal irritation. Aside from overall symmetry, other important function consideration include nasal valve collapse and the oral competence. Injury to the intratemporal portion of the facial nerve can result in total palsy as well as dysgeusia. We have some damage to the geniculate and the proximal to this region can lead to decrease the lacrimation due to the injury of the proganglionic parasympathetic fibers that supply the lacrimal gland carries in the greater superficial petrosal nerve. Some damage to the nerve proximally to the takeoff of the nerve to the stapedius can result in the hypercasis in the affected area. The facial nerve topography as well as nerve stability testing has largely been replaced by more objective electrophysiologic tests. We can list 3 important tests. The first is an electroneurography, and the first is the electroneurography, which are mainstay of the facial nerve testing. The electroneurography is an objective test that measure evoked compound muscle action potential using skin electrode. The nerve injury is expressed at a percentage of function relative to the normal site. When the electroneurography is undetectable, the electromyography testing can be attempted. The electroneurography effective from the post-injury days 3 to the 21, recording facial muscle response at the nasolabial fold to the supramaxillary stimulation over the facial nerve as it excites the stylomastoid foramen. The results are compared with the contralateral side and recorded at a kind of percentage of the deficit. The supramaximal stimulation is applied to ensure that every possible working nerve fiber is tested. A greater than 19% reduction in the first up to the second week after the injury is regarded as a severe neuronal dysfunction, and it is a relative indication for the facial nerve exploration. The electromyography measure voluntarizes the muscle response with the needle electrode placed in the target muscle that affect action potential during the muscle contraction with a functioning nerve. The muscles that have been denervated displays fibrillation potential, while the muscle that is in the process of the renervation demonstrate the polyphasic potentials. Electrical salient in the patient with long-standing facial paralysis indicate severe muscle atrophy and the degrading of motor and plate. Outside documentation of voluntary motor potential at any time, the electromyography otherwise is not useful until the 14 up to the 21 days post-injury, as this is the period required for the neural degeneration to become very, very evident. We have a last test with an electrophysiologic testing which provide information relating to the extent of injury in the basis of the denervation of the facial muscle and may be of benefit in patients with a decreased level of consciousness. The electrophysiologic studies are useful tools in the evaluation of the facial nerve injury, although expert interpretation is essential for this electrophysiologic testing. According to radiographic assessment, the imaging modality of choice for the evaluation of the temporal bone is an actual and coronal high-resolution computed tomography scan, as we can see on the image in this slide. And the scan of the temporal bone can be obtained following initial evaluation and management of the intracranial pathology. A multiplannar reconstruction can be used to identify facial canal fractures or impalement. The anatomy of the temporal bone fracture and the associated fracture as they appear on a CT must be fully described. Associated skull and facial fractures, osculary disruption, hemorrhage in the middle ear or the mastoid hair cell, and the potential injury to the carotid artery can also be appreciated on the CT scan. Some authors like Resnick and colleagues found that 18% incidence of carotid injury in patients with fractures through the carotid canal, and up to 5% of the incidence of carotid injury if they did not fracture. On the image on this slide, the first image is a axial temporal bone computed tomography demonstrating a bilaterally longitudinal temporal bone fractures where there are arrowheads. And in the second image, we have an axial temporal computed tomography which demonstrating a transverse fracture on the right side where we had a narrow head. On the next slide, we have some fracture line which cross the geniculate ganglion on the first image, the ganglion section of the facial nerve where we have our arrow. To the second image, which is performed by the axial computed tomography scan, relieving a bilateral temporal bone fracture. We have a right transverse optic capsule violating and a left optic capsule spurring temporal bone fractures. According to the management of the facial nerve injury, after identifying a facial nerve palsy and its severity, clinical management must be addressed. And initially, protection of the cornea of the eye is a paramount. The intervention includes some conservative measures such as a lubricating ointment and intermittently tapping the eye shut, as well as more invasive procedures such as upper eyelid gold weight and tarsography.
We have some short-term steroid administration which widely used. Although an improvement steroids are thought to improve outcome prematurely by reducing nerve edema in patients managed with a conservative approach. The management of patients with the immediate onset of the facial palsy without evidence of fracture evokes some debate, and most surgeons now tend to favor the compression based on electrophysiologic criteria, and the most frequently cited criterion use the electroneurography. After 72 hours, the patients are followed with a serial of the electroneurography up to 21 to 21 days. If the narration reach 90% or more, and there are no voluntary motor unit potential seen on the electromyography, then surgical exploration may be warranted. Patients whose electroneurography remain below 90% degeneration, or those who volitional motor unit potential are seen on the electromyography, should be managed non-operatively, as the prognosis is very good in this case. And most authors recommended an early decompression within 1 up to 3 weeks after the injury, in order to prevent ischemic injury, retrograde degeneration, and extensive fibrotic change in the nerve. The role of the surgical decompression in patients with a delayed facial paralysis is less clear, because it is a general held that the prognosis for delayed onset facial palsy is favorable regardless of management. And the delayed onset of the facial paralysis is suggests continuity of the nerve with subsequent secondary edema or hematoma formation, leading to a compression of the nerve within the facial canal. Although this dichotomy have been questioned by some authors like Bite. And the choice of the surgical approach is very, as we said into the introduction of this presentation, is based on the site of lesion as determined by the physical examination, by the testing of the facial nerve branch function, the hearing study, and the audiometric data and radiographic evaluation. The choice of surgical approach should be also considered tentative, because exposure of the anterior facial nerve may be required. According to the middle cranial fossa approach, the middle fossa cranial approach is generally performed through a linear vertical or temporal flap incision extending from the root of the zygoma to the superior temporal line, and a small craniotomy is fashioned, and the dura of the middle cranial fossa is elevated. Elevation of the dura must proceed with care, as the geniculate ganglion may have no bone covering in the cases. There are two well-known methods of identifying the geniculate ganglion and the facial nerve in the middle fossa approach. The first method utilizes the greater superficial petrous nerve as a landmark. Drilling begins over the proximal greater superficial posterolaterally until to the geniculate ganglion, and progress posterolaterally until the geniculate ganglion is identified. Drilling can continue to identify the meatal portion of the internal auditory canal portion of the facial nerve. For the second method, which utilizes the landmark on the floor of the middle fossa, an angle is visualized between the long axis and the great superficial petrosal nerve, which is 120 degrees in the opening medially. This angle is bisect, and this bisecting line lateral to identify the meatal segment and eventually to the geniculate ganglion. Once the geniculate ganglion has been identified, the tympanic portion of the facial nerve can be exposed to the level of the cochleariform process. And this approach allows an exposure of the most proximal portion of the intertemporal facial nerve, the labyrinthine segment, and the full exposure of the geniculate ganglion. According to the case of severe injury, we can perform a direct repair or repair with an intrapositionally grafts which may be accomplished, and a great auricular nerve may be used as a donor because it can be exposed in the field and its diameter approximate that of the facial nerve. Combined with the subsequent transmastoid approach, this technique allows a total intratemporal exposure of the facial nerve. And some auto-reported complications of the middle fossa approach include some sensorineural hearing loss, some vestibular dysfunction, a cerebrospinal fluid leak, a meningitis, an epidural hematoma, an injury to the temporal cortex secondary to the retraction. According to this image, we have some, the first image shows a skin incision for the middle fossa approach, the dashed line. The patient's head is rotated to the 90 degree to the contralateral side, and a vertical incision begins anterior to the ear at the level of the zygomatic arc. A question mark incision with dotted line is performed when anterior extension is desired. Example, the Trans-Kawas approach and reaching the petrous apex in the goal. The next slide. The craniotomy for the middle fossa approach on the A image. The skin incision and temporal muscle have been retracted with the fish hooks to expose the temporalis squama and the roots to the zygomatic arc. The craniotomy is approximately a 3.5 centimeters square, and the superior limit is a temporal squama, while the inferior limit is the zygomatic arc as shown here. The coronal showing angle of the intraoperative approach to the temporal bone must be trimmed to minimize the retraction of the temporal bone. Next slide, Ulrich. On the image that we said, the coronal view showing the angle of the operative approach, and the temporal bone must be trimmed to minimize retraction of the temporal brachia. On the second image, the extradural exposure of the important landmark shown a surgical orientation, and the temporal dura has been elevated posterior to the anteriorly, and retraction blade is placed beneath the dura of the temporal lobe. The accurate eminence on the floor of the middle fossa helps to identify the internal auditory canal posteriorly and the anterior limit in the middle meningeal artery. And the anterior and the posterior branch of the middle meningeal artery are identified with the dura elevated, and in some cases, the geniculate ganglion is not encased in the bone. Next slide. And the option for exporting the internal auditory canal, on the image we have a fish technique. A line is traced anterior to the long axis of the accurate eminence, which shows the anterior lobes of the internal auditory canal. And the B image we have a Gracia Ibanez technique. The greatest superior petrosal nerves and the long axis of the accurate eminence are identifying by stretching two imaginary lines over these structures. At the bisection, another line is drawn over the anterior lip of the internal auditory canal. Drilling proceeded along this line to expose the internal auditory canal. And on the image C, we have the house technique with the great superficial petrosal nerve, which is followed until the geniculate ganglion is exposed. and which until the ganglion is exposed, and the labyrinthine portion of the facial nerve is thrust until it reaches the internal auditory canal. It is unnecessary to expose the accurate eminence, thereby reducing retraction of the temporal bone. And the transmastoid approach, a low facial nerve exposure from the geniculate ganglion to the styloid foramen, although successfully described for exposure of the geniculate ganglion, some surgeons feel that inadequate proximal exposure is obtained and prefer combining the transmastoid and the middle cranial fossa approach for the total exposure. A transcortical mastoidectomy can be performed through a retroauricular incision, and the incision to muscular canal and short process of the incus are identified. Is an opening increased just inferior to the short process of the incus to enter the facial recess, and through the opening the echidostapedial joint and the second journey of the facial nerve, which are identified. The bone overlying the descendant portion of the facial nerve is thinned and removed to the stylomastoid foramen. It is important to note that additional exposure can be obtained to visualize the geniculate ganglion by disarticulating and removing the incus, which cause conductive hearing loss. The conductive hearing loss can typically be corrected via a osculoplasty. Next slide. According to the right transmastoid approach for the compression of the facial components of the facial nerve, which is shown, the next image, please. Okay, yeah. As I said, a right transmastoid approach for a decompression of the distal component of the facial nerve is shown on this image. Following with a transcortical mastoidectomy of the facial nerve, which is identified and treated proximally to the facial recesses. The incus can be dislocated and rotated or removed to allow exposure of the second genus of the facial nerve and the distal aspect of the geniculate ganglion. And it is important to know that the facial nerve can then be decompressed in its bony canal from the level of the geniculate ganglion to the stylomastoid foramen. According to the second approach, which is a translabyrinthine approach, the translabyrinthine approach allows visualization for the internal auditory canal to the stylomastoid foramen for either decompression or nerve repair, and the great auricular nerve is accessible for cable graft repair. The main condition for the use of the translabyrinthine approach is that hearing completely lost and a retroauricular incision is performed and a total mastoidectomy is performed with a high-speed drill. The drill is used to remove the bone over some of the posterior fossa dura to the sigmoid sinus and the posterior fossa dura anterior to the sigmoid sinus and the middle fossa. The facial nerve should be identified either inferior to the lateral semicirculate canal or in the mastoid portion. The labyrinthectomy is started by removing the lateral semicirculate canal. The removal extends posterior and the posterior semicirculate canal is entered. The posterior semicirculate canal is opened in the common crus, and the removal is now extended. According to this image, we have a translabyrinthine approach of the facial nerve, and on the image we have the mastoidectomy, which has been performed, and the facial nerve canal had been identified from the lateral semicirculate canal to the stylomastoid foramen. The bone labyrinthine has begun to be opened, and to the image B, the removal of the labyrinthine and exposure of the facial nerve has been completed. The facial nerve has been exposed from the internal auditory canal to the styloid foramen. And it is important to know that the internal auditory canal, the internal acoustic canal are represented here as we said already. According to the conclusion, as we said, the role of surgical decompression in facial nerve injury remain controversial, and the management of facial nerve is continue to evolve. A review of available literature provides guidelines for management of the patient with such injuries, but randomized prospective trials are lacking, and most authors agree that an immediate or early onset late post-traumatic facial palsy with 90% or greater degeneration seen on the electroneurography and the absence of voluntary motor unit potential should be undergo exploration. And the role of the surgical intervention in delayed onset facial palsy is less clear. Although while it lies the role of steroid in management of such patients is based on an anecdotal evidence, and a review of the literature on the management of the lesion highlight the need for a systematic controlled study to optimize the management of patients with a facial nerve injury. And many patients who have suffered from injury to the facial nerve are managed by neurosurgeons and otolaryngologists, and the role of neurosurgeon in coordinating an appropriate management among these disciplines require a thorough knowledge of the natural history and available literature regarding of the facial nerve injury. And here we are at the end of our presentation. We thank all of you for listening to us. Thank you.
Great. Thanks. That was a comprehensive and detailed presentation. Very, very good presentation. I mean, this was a lot better than the last one you presented. So clearly you're improving, and that's very positive. You always want to be improving. Thank you so much.
Thank you, Ulrich.
Dr. Jimo, do you have any comments? Shoot.
Well done. This Dr. Hassan has done a great job. He has taught everything: anatomy, pathophysiology, and operative care of this case, and it's very comprehensive. Really, he has gone home in saying everything. I guess there's nothing to add other than to say he has done extremely well. He's well researched, and he took his time to make all the points. Well done.
Yeah. Well, thanks for him. He's really done a great job. Dr. Natalie, do you have any comments perhaps for us?
No, comment va?
Dr. Natalie?
Yes, I speak Spanish. Yes,
John, you might want to mute. Oh well, yes, I'll say the presentation was very detailed, well structured. You covered everything. Really great job. We're really happy about this. I mean, these are the kind of presentations we want to see. We want to see this kind of quality and application. It shows that you really spent the time. We took the time to search the content, and yes, really great. Dr. Igor, do you have any comments or questions?
No, I don't have any comments. The subject is very clear, and he has a great job.
Okay, great. And finally, Dr. Yanu, do you have questions, comments, perhaps?
Yeah, I just want to thank the presenters for the very nice presentation.
He's trying to speak.
I was saying, hello?
Yes.
Okay, I was saying I just want to thank the presenter for the brand presentation.
Okay. Okay. Well, thanks for him. I mean, we've had some really good presentations today. We hope to see you then next week for other presentations. Thanks for being around, and thanks for everything. Have a great weekend and a great week coming up.